Hello, Nursing 120 class. Today's topic is on elimination. This is a very essential function to the human body, something that's very important for our patients. The learning outcomes and objectives for this presentation are to describe normal urinary and bowel elimination across the lifespan, discuss normal characteristics of urine and stool, identify the factors that may alter elimination, be able to gather objective and subjective data during a physical assessment, and the patient health history to find out what bowel and bladder function is normal for the patient. Identify nursing diagnoses related to elimination, and then develop a plan of care with goals, outcomes, and interventions that support a normal elimination pattern. It's also important to discuss pharmacological agents and enemas used to treat bowel and bladder elimination issues. Let's review the urinary system. Kidneys receive as much as 2,000 liters of blood flow daily, and each kidney contains millions of tiny filters called nephrons. Nephrons extract waste from the blood and play a key role in fluid and electrolyte balance. Although tiny, the nephron consists of a glomerulus, a Bowman's capsule, a proximal convoluted tubule, down to the loop of Henle, a distal tubule, and the collecting duct. The intricate kidneys have a big job. They do filtration of water, glucose, amino acids, urea, uric acid, creatinine, and electrolytes. They also are involved in reabsorption. They help maintain fluid and electrolyte balance. Only 1% of filtrate is excreted in urine. Kidneys are also involved in the secretion, production, synthesis, and activation of multiple substances, including urine, erythropoietin, which stimulates RBC and bone marrow production, renin, which is an enzyme that helps convert angiotensin to 1 and 2. This is involved in the body's water retention. Prostaglandin is a hormone, maintains renal blood flow and blood pressure. And then vitamin D is converted into a usable form here in the kidneys. Other parts of the urinary system include the ureters that carry waste from the kidneys down to the bladder via peristalsis. Our bladder is a hollow, fixed portion and distendable portion organ. It's very muscular and can stretch. The urethra in the female is 1.5 to 3 inches, whereas in the male it is about 3 inches and involved both in urine production and reproduction. Urination also has a more medical term called micturition. It requires the contraction of the bladder with relaxation of pelvic floor muscles. This involves several areas of the brain and 2 areas of the spinal cord. Urination is a coordination between bladder and pelvic floor. When the bladder fills and stretches, bladder contractions are inhibited. This is the sympathetic stimulation. There are many complex factors that influence urination that we have to consider when assessing our patients. Sociocultural, think about it, indoor plumbing versus what is available. Maybe it's an outhouse, a river, a field. Also, is it a private versus a shared space? And religious and culturally, who is permitted to assist your patient with elimination? Psychological. Anxiety and stress can affect the sense of urgency. Anxiety can impact the relaxation of pelvic floor muscles and can result in not adequately emptying the bladder. Muscle tone decreases as a person ages. It also changes after a woman has children, related to the pressure on the bladder and stretching out of those pelvic floor muscles. Then fluid balances. Increased fluid intake causes increased fluid production. Also, diuretics, such as caffeinated beverages and medications, increase fluid elimination. And alcohol decreases the amount of antidiuretic hormone produced, so that urine production is prominent. So urination changes across the lifespan. Some factors that influence urination for growth and development. Think about infants. Infants produce 400 to 500 milliliters of urine daily. It is usually yellow and clear as long as the infant is hydrated. As people begin to become toddlers, they start to associate the sensation with the bladder, filling, and urination. This is why between ages 2 to 3, potty training begins. In adults, we produce 1,500 milliliters of urine daily, looking for a normal of at least 30 mLs an hour. Older adults may experience a decrease in bladder capacity and the ability to hold urine for long periods of time. Older adults are at increased risk for urinary incontinence related to chronic illnesses, decrease in mobility, or cognitive issues. More factors influencing urination. Think of disease conditions, renal issues like acute renal failure from shock, medications, infections, renal failure to end-stage renal disease, which requires dialysis. There are diseases that affect micturition. Might have damaged peripheral nerves, which decreases bladder control. Things such as diabetes mellitus, cognitive impairments, or BPH, benign prostatic hypertrophy, where the prostate gland becomes enlarged as men age, adding increased pressure onto the bladder. There are also diseases that slow physical activity, such as rheumatoid arthritis and osteoarthritis, Parkinson's disease, and then traumatic injury. The spinal cord is a very important component of bladder and bowel function. A stroke or spinal cord injury can really affect how a patient is able to urinate. Medications can be big factors influencing urination. Diuretics prevent the reabsorption of water and electrolytes to increase urine output and are often used for blood pressure regulation. Some examples of diuretics include thiazide diuretics like chlorothiazide, loop diuretics like furosemide, also called Lasix. Then our potassium-sparing diuretics like spironolactone. Anticholinergics are medications usually used for IBS or irritable bowel syndrome, help increase water absorption for peristalsis. Then antihypertensives, beta blockers, antihistamines are made to help dry you up if you're having allergies or runny nose from a cold. So these lead to urinary retention. Also, medications can cause urine color changes. Urine might become orange if a patient is taking niacinamide, like an antibiotic for TB, or a sulfasaline for rheumatoid arthritis, colitis, or even a riboflavin. The urine might become brown if they're taking one of the antibiotics, Flagyl or Macrobid, and even a bright red if they're taking rifampin. It's important to look at your patient's medications when assessing their urine to see if that could be a potential cause for any color change. So what's involved in the physical assessment as we think about elimination with our patients? First, most basic, we want to look at skin and the mucous membranes. Does the patient appear to be hydrated? Then we want to move down towards the kidneys. If there is flank pain, this can indicate inflammation or infection. When looking at the bladder, we want to see, does the bladder appear to be distended? If it's distended, it will rise above the pubic bone symphysis, and also will have some pain and discomfort. The urethral meatus, we want to look for any presence of discharge, redness, irritations, and possible lesions or sores. This chart helps review all the different possibility factors that your patient might have and to take into consideration when you're doing your assessment. You want to know what their voiding patterns are like at home, and are there psychosocial factors that maybe impair them from being able to empty their bladder or their bowel. History of infections. Is this a patient that has frequent urinary tract infections? That's something that's important to know. Are there certain medications? Are there certain hygiene things that the patient is or isn't doing? If it's a male and he's above the age of 60, 65, there's a good chance he's had BPH, and that can be a big factor in causing urinary retention. So taking a thorough history, gathering as much assessment data as you can, helps rule out what's normal versus what's not normal for your patient. There are several ways that we do an assessment of urinary elimination. We need to assess the urine, of course. How much is the patient voiding? This is important to get I and O's, or input and output. We're looking to see that they're outputting at least that 30 mLs an hour. If not, there could be an issue. What are the characteristics of the urine? The color, the clarity, the odor. This is why I have this picture of this nose here. You can develop a nursing nose, and you'll soon learn to detect possible urinary infections by the presence of a strong odor. And then not just by, the subjective data of looking at the urine, smelling the urine, noting the color and looking for any sediment in it, we need to send the urine off for testing and specimen collection. When collecting specimens, it's important to get a clean catch specimen or sterile sample from the sample port of the urinary catheter. We don't want to give a false positive test for our patient. This is an example of what a urine collection specimen cup looks like, as well as the urine culture tube. So for the urine culture tube, you would get your specimen in your little container there, and then by putting that test tube into that white catcher needle, it will suck up the urine into the test tube, and that is sent for a culture. When we suspect issues with the urinary system, there are multiple diagnostics that we can use. The urinalysis, such as I mentioned, those results will be back within a day. A culture really takes 48 to 72 hours, giving a chance for any bacteria to grow out. We look at the specific gravity of urine to see what kind of filtrates are in there. Then we can do diagnostic examinations. These do require consent, and we also need to be considerate of allergies that the patient might have, because these do involve some injection dye. An intravenous pyelogram, or PVP, and IVPs look at all the structures in the urinary system. It involves IV injection of contrast. Ultrasounds, we're looking for gross abnormalities within the renal system, within the kidneys, within the ureters, the tubules. And then endoscopy uses a scope, and it really helps visualize possible tumors or obstructions within the renal system. There are other lab values that help us determine how well the kidneys are functioning. In the serum, we look for the BUN and the creatinine. BUN, also known as blood urea nitrogen, tests how well the kidneys are working. Nitrogen is present in chemical urea. It's a waste product produced by the breakdown of proteins. Urea is then carried by blood to the kidneys, which filter it out into urine. The creatinine can be measured in blood and urine. It is a byproduct of muscle metabolism and estimates the effectiveness of glomerular filtration, or GFR. As we start to see these levels rise, creatinine and BUN, it means that the body is not filtering as it should. And this is a big sign that there's potential for kidney failure or kidney damage if there's not something done about it. So we always want to try and promote as most normal function of micturition or urination for our patients as we can. This may mean we have to position them differently. If they're not able to get out of the bed and have to use a bedpan, that's not natural, but we could position the bed into a sitting chair position so it feels more like they are using a commode. We want to allow for privacy. It's hard to kind of do what you need to do if you feel like someone is watching you. If safety is an issue, it doesn't mean we leave the patient completely alone. Maybe we just step behind a curtain so we're still present in the room. Give the patient adequate time. Don't rush them. Give them a chance to do what they need to do. And also preventing infections, hygiene. making sure that we are wiping appropriately. For females, it's very important to wipe from front to back, not back to front. That might spread around fecal matter. It's important to also wash your hands. That's a really big deal for every type of prevention and infection. And then looking to acidify the urine. If the urine has an acidic environment, then it's harder for bacteria to grow. Promote complete emptying of the bladder. Encourage fluid intake. Also, maybe they need sensory stimulation. Being in a hospital environment is not natural. So maybe we have some running water in the sink. Maybe we put the patient's hand in water, in warm water. Maybe we warm up the bedpan so that it's not quite so cold. We can even use the sound machine or through the TV playing a waterfall or brook or beach scene. I have pictures here of a waterfall, just as an example, and also of cranberry juice. You may have heard that you can drink cranberry juice to help prevent urinary tract infections. This just goes along with increasing the acidity of the urine. Some common urinary problems that you might encounter as you assess your patients, particularly after surgery or traumatic illness, is urinary retention. You'll notice this by distension, tenderness in the pelvic bone region, restlessness, diaphoresis. We use a bladder scanner that helps determine the volume of urine retained. Usually, if it's been a 6 to 8 hour period and the patient either hasn't voided or they voided very little, if there's more than 300 milliliters of urine still left in the bladder, it might be time to consider doing an in and out catheter or placing an indwelling urinary catheter. Urinary retention can be caused by trauma, anxiety, the motor and sensory innervations if we've had a spinal cord injury, urethral obstructions, BPH, such as I mentioned with aging male population. Then anesthesia. Anesthesia it puts everything asleep during surgery, and sometimes postoperatively the bladder has a difficult time waking up. And then considering other medications that the patient might be taking, such as pain medicines or anticholinergics that might be drying them up and not allowing them to completely empty their bladder. Urinary tract infections are a big deal, and we know that it's something that we don't want our patient to get on our watch in the hospital. If someone has bacteriuria, this can spread and lead to urosepsis throughout the whole body. We really need to watch with chronic indwelling catheters or frequent in and out catheters that we're using good sterile technique. Poor hygiene is one of the biggest contributors to urinary tract infections. Also, holding urine for prolonged lengths of time. Those of us that are, nurses and standing, working long shifts, not using the bathroom, not hydrating, teachers, other service industry personnel could be at risk for having urinary tract infections. Some signs and symptoms are burning on urination, pelvic and low back pain. As the infection progresses, getting fever, fatigue, noticing that odor to the urine, a dysuria where you are going to the bathroom frequently but not really completely emptying the bladder, hematuria or blood in the urine, and then very important to consider is in our elderly that one of the first signs they might have urinary tract infection is confusion. There are many common urinary problems that develop, and one of these is urinary incontinence. There are multiple types of urinary incontinence that we're going to discuss here. So transient is caused by medical conditions and is usually treatable and reversible. Transient can be a thing like a nerve compression, and with post-surgery, as that nerve is decompressed, the patient's bladder continence improves. Functional, this is caused by factors of environment, clothing that might be tight and restrictive, toilet access is restricted, so those things can lead to this type of incontinence. Stress. This is involuntary leakage upon increased abdominal pressure. thinking about, if you're just laughing too hard, coughing, sneezing. Um, Unfortunately, this is something that happens to women a lot after they've had multiple childbirths or as women age and those pelvic floor muscles become weakened. This is something that you can improve with pelvic floor exercise called Kegels. Overflow incontinence is associated with chronic retention. So it may be helpful for your patient to practice timed voiding. At certain times throughout the day, they're going to the bathroom, whether they're getting that sensation they have to go or not. This just prevents that overflow. These patients may even need an intermittent straight in and out catheter, just so that we are routinely emptying that bladder and not risking overflow. Urge and hyperactive bladder. Overactive bladder is an involuntary release of urine after a strong sense of urgency. So once again, as people age, they might just get this strong sense that they have to go right away, and they may be experiencing dribbling or just inability to hold the urine until they make it to a restroom facility. So it's important to kind of avoid bladder irritants, like caffeine, carbonated beverages, even artificial sweeteners. You can do bladder training to help strengthen those muscles. Again, keeping routine times that we're going to try and go to the bathroom. Behavioral interventions, especially with people with dementia or confusion. They may not say they have to go to the bathroom, but as a nurse, a caregiver, you're going to take them anyway. Like, we're going to go ahead and intervene and take them, because that ability to comprehend the sensation they need to go might not be there. Antimuscarinic medications are like ditropan. Those help relieve the bladder spasms that decrease that urge, that hyperactivity. Reflex incontinence is an involuntary loss of urine related to the spinal cord injury. If there is damage at the cervical 1 through the sacral 2, there could be nerve compression that just leads to the patient's inability to know if they have gone to the bathroom, or maybe they can't release the pressure on the bladder. Those nerves are not functioning appropriately. And then there can be a combination of these different types of incontinences, a combination of urge and stress incontinence. You've reached a point where you have to go so bad, and then the stress on the bladder, it can't be held. So just kind of working on some different interventions to help your patient with these issues. You may care for a patient or even have a friend or family member that's had to have a urinary diversion. Patients that have had bladder removed related to cancer or significant dysfunction, they might have ureterostomy. This is a permanent urinary diversion. It closes off the internal portion and reroutes to a stoma where urine is collected in a pouch. This little pouch can be internal, where they'll go in with an in and out catheter and kind of drain it, or it can be an external pouch that's just directly emptied into a toilet. Ileal conduit diverts into a portion of the ileum and drains out into a stoma. This may not be long-term. It may just be after repair of some damaged kidney or kidney stones or blockage. So maybe permanent, might not be. Urinary diversion. These are the use of nephrostomy tubes. These are small tubes that are tunneled through the skin into the renal pelvis. And these are also don't have to be permanent. They're used when the ureter is obstructed, maybe from a kidney stone, an injury, a traumatic injury has crushed the kidney, or acute infection. And patients can go home with these tubes, and you have to do good teaching so they know how to maintain them and use proper hygiene so they don't get an infection. And they're temporary. They'll go back to the urologist office and have them removed. Just imagine there are many challenges for patients with urinary diversions. I encourage you to look on YouTube. There are lots of people out there kind of getting this out in the open, telling their stories. And I'll give you some links to some of those on the Moodle page so you can watch those and just kind of see what people go through and how they've learned to live with it and just carry on with a normal life. Some other important facts to know about care of catheters. Ensure that the catheter bag hangs below the level of the bladder and is never on the floor. Also make sure that the bag is never more than 3/4 full. This can lead to backflow into the bladder that can lead to infection. And also think about it, that would be quite uncomfortable for your patient to have a heavy weighted bag tugging on their bladder. And then once again, pericare and documentation of catheter care. This is a big risk for infection as a source for nosocomial infection or hospital-acquired infection. If our patients get an infection on our watch, there's a chance that their hospital care will not be paid for by their insurance. So keeping patients healthy while they're under our care. So now that we've assessed our patient and their renal function, what are some nursing diagnoses we can use when thinking about their plan of care? Maybe they don't have an infection or urinary tract infection, but are they a big risk for it? Do they have that catheter in place? Incontinence, and if so, what type of incontinence is it? Remember the different types: stress, reflux, functional, urge. Do they have a body image disturbance? They aren't able to get to the bathroom like they normally would. Toileting, is there a self-care deficit? Once again, is mobility limiting the patient? Maybe they've just had a big back surgery and something as simple as wiping and cleaning oneself is very challenging. Impaired urinary elimination, are they retaining urine, urinary retention? Is there pain upon urination or pain with a distended bladder? And then knowledge deficit. Is there some knowledge deficit regarding their hygiene, regarding maybe some training and bladder training they need to do to avoid overflow incontinence or stress incontinence? Maybe we can educate the patient on doing Kegel exercises. These are all important considerations as you create your plan of care and looking at your nursing diagnoses. Now let's discuss the GI system. The GI system and bowel function becomes really important to patients who are in a hospital. Basic review of the GI system: we start at the mouth, down through the esophagus, stomach, small intestine, large intestine, down through the anus where waste is removed. The colon has 3 functions: absorption, it reabsorbs water, sodium, and chloride; secretion, peristaltic contractions move waste down through the colon; and then elimination is vertical and transverse folds of tissue for expulsion through the rectum. Just like bladder function, there are many factors that affect bowel elimination: age and the developmental changes with aging, a patient or a person's diet, how much fiber is in their diet, do they eat a lot of gas-producing foods such as onions, broccoli, beans, do they have enough healthy flora in their gut, how is their fluid intake. Physical activity helps maintain muscle tone and increase peristalsis for digestion. Also, psychological factors: anxiety and privacy. You're out of your abnormal routine. Maybe people or yourself have experienced when traveling, just in a different environment, and that adds added stress to get out of your bowel routine. And other diseases like colitis, IBS, Crohn's disease, gluten intolerance or sensitivity, and inflammatory bowel disease. These are all factors affecting bowel elimination. Continuing on with other factors affecting bowel elimination: body position. Think about trying to use the bathroom when you're lying in bed or you're bedbound. It just doesn't feel natural. So helping patients position. Pain. Is there pain upon having a bowel movement, such as hemorrhoids, rectal surgery, fistulas, where a opening or hole develops between the rectum area, abdominal surgery, and back surgery? There might be some fear there that straining to go to the bathroom is going to add added pain. Pregnancy kind of slows down everything. A lot of women get constipated during pregnancy. Surgery and anesthesia. Mentioned earlier with bladder function that anesthesia can put everything to sleep. This includes the bowels. And along with that, you're also receiving narcotics, which further slow down peristalsis. This can lead to paralytic ileus. The anesthesia slows everything down, and then patients kind of get a large amount of air trapped in their colon, or if they haven't had a good bowel cleanse prior to surgery, there's trapped waste, and this can become a big issue. There are also diagnostic tests. If someone's given a lot of bowel prep, maybe go lightly before colonoscopy. This is certainly going to increase their elimination pattern from what it would be normally. Across the lifespan, bowel elimination starts to change. Adults and older adults, bowel motility starts slowing down. There's the weakened pelvic floor muscles. As patients become less mobile, their decreased activity slows their metabolism, which slows their reduction of waste. You may have patients that start getting very concerned if they don't have a bowel movement every single day. But just encouraging them, that it doesn't have to happen every day, just as long as we're not uncomfortable, still having good bowel sounds. There can be a decline in strength of the sphincter muscles that lead to decreased tone and control. This can be a source of embarrassment for some patients. And then there's laxative overuse, which can lead to laxative addiction. The body becomes so used to the use of laxatives that it's unable to really function without them. This becomes a problem if you can't naturally rid your body of waste. Here's another chart of a list of medications that can affect bowel elimination. Your antacids, aspirins, and nonsteroidal anti-inflammatories always need to be careful, particularly in elderly patients, because they can lead to GI, stomach bleeds. Antibiotics, we're trying to kill bad bacteria, but at the same time, good bacteria in the gut of the stomach is being killed, so this can lead to diarrhea as a result of those antibiotics. Iron supplements, a lot of people with anemia or pregnant ladies have to take iron. This further adds to more constipation. Pain medications, as I mentioned earlier, they slow down peristalsis, and patients tend to get backed up and constipated on pain medications. Anti-motility meds, you've been having diarrhea, so now you want to take something to counteract that. Just have to try and find the right balance. Anticholinergics, their job is to kind of dry patients up if they are, having too many secretions or allergies. If you're drying things up, you're also not getting enough liquid to the bowel and to the stool, which makes it difficult to pass. So hydration is very important when patients are taking anticholinergics. And then laxatives, of course, our result that we want for laxatives is that they help the patient be able to have a bowel movement. So how can nurses help promote normal bowel function or defecation? The hospital environment, it's hard to have privacy, but it's the same thing with bladder. If your patient, for safety reasons, you can't leave the room to give them privacy, just maybe stand behind the curtain while they're using the bedpan, or stand behind the cracked bathroom door, not leaving the room, but still providing that privacy. Positioning. Once again, you can sit the patient up in bed in a more chair-like position, or really work to get to a bedside commode if they can't make it all the way to the bathroom. This just makes it a more natural process of being able to have a bowel movement. Timing. Trying to keep the patient on a schedule and noting when their last bowel movement was on your assessment. Fluids and nutrition. Fluids are very, very important to stay hydrated, to add moisture to that stool and that waste to help it be able to pass. And then your fruits, your vegetables, your whole grains, those have our most fiber in its purest form. And really, anyone needs to get 20 to 30 grams of fiber daily. Also restrict carbonated beverages. This just adds added gas and bloating and further discomfort if a patient is already constipated. Then exercise. Patients in a hospital setting, might not be getting what we consider a lot of exercise, but even just walking around the unit, getting out of bed to chair for meals, this counts as activity. We need that activity and that gravity to help increase peristalsis, as well as help maintain abdominal strength. And they can do some exercises to help increase abdominal strength as well. Gathering assessment data regarding your patient's bowel elimination patterns is important to help differentiate what's normal, what's new, what's different. How is their elimination patterns? Are they someone that's very concerned if they don't go every single day, or someone's normal to go every couple of days? What is the characteristics of the stool? If it's small and hard pellets, there's a good chance that that patient or that person is not staying hydrated. What medications is the patient on? Are they having to use enemas at home? Is there any sort of bowel diversion? Have they had a change in diet, change in appetite? Maybe they're not getting as much fiber, or they have a hard time getting fresh fruits and vegetables. Is there presence of gas and bloating? And then stress, emotional states, maybe development of anxiety, development of ulcers, or just not wanting to eat, eating too much. All of this will affect bowel elimination. Exercise habits, discomfort when going to the bathroom, and then kind of a social history. Were there any issues, bowel issues in the patient's family? Mobility and the patient's ability to perform their own ADLs. If it's someone that has a hard time getting up and getting to the bathroom, they might not want to be regular. They might kind of withhold going to the bathroom, which isn't good. That ultimately leads to constipation and further issues. Or be self-conscious about losing control. Flatulence, this is a decrease in intestinal mobility, can cause gas, opiates, and surgery. Or with anesthesia, they're injecting a little bit of air to do the breathing tube. All that can add to increased gas. Also being immobile, and then types of foods. And flatulence can be very painful, can cause severe abdominal distension, bloating, and pain. And some patients, if they already have had some sort of surgery, having this increased flatulence and gas pressure adds even more pain to their incisional site. Another thing to mention is withholding waste. Not just people who are incontinent and maybe can't get to the bathroom or don't want to get up for fear of pain, but think of small children who are scared to go to the bathroom. This can be a problem if they're holding their waste, can lead to impaction and constipation and severe GI issues. So there's more specific data you need to collect if your patient is reporting constipation. What is the consistency of the stool? Is it hard, small, dry stool, what we sometimes call rabbit pellets? Has the patient been having to strain? Is there a decrease in appetite, back pain? Are they starting to get a headache now and a feeling that they're full? Abdominal distension. You'll see patients that look like they're almost pregnant because their abdomens become so distended. And then the bowel sounds. Are they hypoactive? Or they might even be hyperactive. You'll hear the sound of gas and gas pressure just trying to move, trying to escape. And then denying the urge to defecate. These are the patients that just, maybe they've had a big surgery and they don't want to get up and move for fear of pain. Also with diarrhea, there's more data we need to collect. Is there a fever associated with it? Is the patient experiencing weakness or malaise, maybe from electrolyte imbalance? Also, electrolyte imbalance can lead to confusion. How frequently is the patient having diarrhea? And is there a really sense of urgency, like they can't even make it to the bathroom? And then doing an assessment of the rectal area, patients that have multiple events of diarrhea will start to get perirectal skin irritation and breakdown. And then find the duration of this. Is this something that is chronic, the patient experiences all the time, or is it just acute episodes? So let's review what some of the diagnostics are for bowel specimens. So stool specimen collection, you can do a culture that might look for some bacteria like Salmonella, Shigella, C. diff, and others. Also could look for parasites or eggs such as Giardia and Lamblia. White blood cell and red blood cell count is the hemoccult, noting if there is blood in the stool that might be symptomatic of a GI bleed. Then there's also radiologic examinations, colonoscopy, endoscopy, also known as EGD, and a sigmoidoscopy, where they go in the sigmoid area of the colon. It's important to be mindful of your patient's culture, maybe where they've lived. Some cultures in areas of the U.S. and the world are at risk for parasites and worms related to unclean water or undercooked rotten meat. If a patient goes for an EGD, this is so that the physician can look inside the esophagus, stomach, and duodenum. And a reason a patient might go for this procedure is if they're having swallowing difficulty, nausea, vomiting, reflux, pain, or chest pain, and we can't really pinpoint the exact cause. This gives a really good picture, as you can see here in the diagram, of kind of the view you would have through an endoscope. Further diagnostic testing of the flexible sigmoidoscopy, this gives you a visualization of the large intestine, all the way from the rectum through the sigmoid and descending colon. Some of the signs and symptoms your patient might be having are diarrhea, abdominal pain, constipation, and this is a test that really helps look for early signs of cancer in the descending colon and rectum. Maybe your patient's been having bleeding, inflammation, there's been some abnormal growth cited or ulcers in these areas. This exam cannot detect polyps or cancer in the ascending or transverse colon. It's really just for the lower portions of the rectum and sigmoid colon. There's really been a big push to start getting patients and friends and family, once they're above the age of 50 or earlier if they're higher risk, such as having a cancer history, a family history, or maybe some abnormal signs and symptoms, to get a colonoscopy. This shows one of a television anchor going live on a morning news show to get his colonoscopy, just kind of taking away the stigma that's a really scary procedure. So what does a colonoscopy do? It's a visualization of the upper portion of the large colon. They use a fiber optic instrument that's advanced up to 180 centimeters to reach the ileocecal valves. It can identify inflamed tissue, abnormal growths that they call polyps, and ulcers. It's most used exam to look for early signs of cancer in the colon and the rectum. And so maybe the patient's experiencing changes in bowel pattern, abdominal pain, they're having some unexplained rectal bleeding or weight loss. So it's really a good exam to have. It's part of preventative care and covered by most all insurances. Once again, once you're age 50 above or have a significant history. So now we'll discuss some of the conditions and diseases of the GI tract. Patients can have obstructions, adhesions, or extra growths of tissue. There could be diverticulitis, which is an inflammation where pouches along the inner line of the intestine develop. Cancer would be shown in tumors and growths. There's Crohn's disease and other inflammatory autoimmune disorders such as gluten allergies that give patients lots of GI issues. And then trauma to the GI area, the GI tract. Because of certain diseases and conditions, Some patients and people out in the community are forced to have bowel diversions. This just provides a way for waste to be drained. It can be temporary or permanent. And certainly you have to think about the psychological considerations for this. It's a really big lifestyle change to have a pouch around you. You might be self-conscious, of odor, of intimacy, of what clothing you can wear, not wear. There are multiple types of diversions just depending on where they take place along the colon. Colonostomies may be in the ascending, the transverse loop or double barrel, descending, or the sigmoid colon. And there's differences between a colostomy versus ileostomy. Colostomies are made from a section of large intestine. Stool consistency depends upon where it is. If it's in the ascending colon, further up, the output's going to be more liquid to pasty. If it's in the transverse colon, it'll be pasty to semi-formed. And the sigmoid colon is going to be more fully formed with the consistency of what we would consider a normal bowel movement. An ileostomy is created in the small intestines. The stool consistency is liquid but can thicken over time. And because it is liquid and more acidic, the leakage is very irritating to the skin around the stoma. So really have to be consistently monitoring any stoma for signs of redness or irritation. And you can have what's called a continent ostomy with ileostomies. It's called a cock pouch, ileoanal pouch. There's a little incision where the person with this type of ileostomy can go in and drain that pouch with almost like a in and out catheter tube directly into a toilet. And it keeps them more on a regular routine of doing this. And the cock pouch is really great for people that have had IBS or Crohn's disease. It's a discreet way to help manage their disease and give them some quality of life. Well, let's briefly review exactly what stomas are. So stomas are opening of the bowel through the abdomen. I have a couple pictures here. The one up top is where a healthy, nice-looking stoma, where the appearance should be red, shiny, and moist, just like mucous membranes. They're not painful. Below them, we see some that are starting to have some issues. A purple, blue, or pallor, kind of gray and dusky, notes decreased perfusion and circulation to the stoma. And then that one towards the bottom next to the incision, it's just really not looking good. You should not be bleeding, but you just need to use caution because stomas could bleed easily if they're bumped, especially if they're a new stoma. Certainly don't want to see any black or necrotic tissue. These are signs that there's really infection. The stoma is just not healthy at all, and really need to consult wound care to take a look at that if you assess that on your patient. Another important note when talking about laxatives is that the bowel prep for colonoscopies. A stimulant cathartic is what we use for that. So the stimulants such as a Go Lightly would be something that would be used. So now that we've assessed some bowel issues with our patient, we need to put this into nursing language. What are the nursing diagnoses related to bowel elimination? Is it bowel incontinence, constipation, diarrhea? Are they having toileting? Is there social isolation related to embarrassment? They just have a hard time being able to be on a routine bowel and bladder schedule in the hospital setting? Are we noting fluid electrolyte imbalances that are maybe leading to the constipation? Is there impaired skin integrity, whether it be around a stoma, around a rectal area? Is there anxiety that's leading to an upset in the GI system? Does the patient have a disturbed body image related to having new colonoscopy, ileostomy, or they're having incontinence and it's something new for them? So here are our references. Please review your Lewis and your Potter and Perry. Medscape has some good things as well. I'm going to provide some great YouTube videos on our Moodle page that shows some stories of some people that have had colonoscopies, ileostomies, and kind of how they're able to live a normal life. I think that's what we want for our patients, is just to educate them, not just in the hospital, but how can they maintain their GI and renal function once they get home, so they can help heal and recover.